السلام عليكم. صباح الخير مرة ثانية. You are welcome back to the ninth session of the 21st annual meeting of the society. This session we have 4 presentations, and I will moderate it with my colleague Dr. Abdurrahman Al-Matari. Abdurrahman Al-Matari, he is a consultant and neonatologist and the leader and program director of fellowship at King Fahd Medical City Riyadh. Abdurrahman, go ahead.
بسم الله الرحمن الرحيم. السلام عليكم. أسعد الله صباحكم جميعا. Okay, our first speaker going to be Dr. Tariq Al-Uwaida. He is a consultant hepatopathologist. He graduated from, he obtained his College of Medicine from King Saud University Medical at Abha, and he obtained a fellowship from Australia. Also, he is a fellow, American College physician from Philadelphia. Thank you. Dr. Tariq, you can start.
Assalamu alaikum. It's my pleasure and honor to be here among neonatologists and to share experience, and I'll talk about the blood products and the complication. All of us knows the blood is quite important, and the blood is quite precious products, not easy to be found. Most of the time it's human to human transfusion. So the optimal use and better utilization of the blood products is a mandate everywhere, and it will continue. During this lecture, I'll try to have some introduction, then just explore what are the blood products we have available in the blood banks for patients. What are the blood substitution, which we are trying to push more for blood substitution rather than the blood, because as I mentioned, blood is most of the time is not easy to find, and whatever number of donors we have, still we will have more demand than the supply. Transfusion related complication is not a simple thing. It's very complicated. I'll try to shed light on some of these points, and finally I will just shed light on the transfusion in the neonatal period with some of the guidelines that being recommended for that. Transfusion, if we go to the history, it was started in 1600 by Samuel Babas, and then the first successful human transfusion was in 1828. Then Landenster, who is the father of the recent blood transfusion, almost 100 years or 120 years, described the ABO group, and then Liffen described the RH group, which are the two major groups that we concentrate on to give the compatibility of the blood and minimize the incompatibility. As we all know, the transfusion is meant to improve anemia, restore volume, improve oxygen delivery, suppress ineffective erythropoiesis, particularly in disorders where there are hemolysis, chronic hemolysis like thalassemia and sickle cell, and in addition to that, we have blood products that will help us to stop the bleeding, and sometimes we need to use blood products that would fight infection. I'll try to go through some of these and explore what are the products and where we can use these products, and what are the complications that may happen with these products. Whole blood, which is the first collection, and it can be used as a whole blood or can be fractionated more, and we will talk more about it, and that fractionation can result in red blood cells or packed red blood cells, platelet, plasma, and the plasma is a full of many things that either we give it as a whole fresh frozen plasma, or we fractionate it to factors, immunoglobulins or albumins. And finally, the least used granulocyte, which is only used in particular situation where we need granulocytes to fight infection, and we have no production, particularly post bone marrow transplantation or in severe aplastic anemias. This is the whole blood which we collect either automated or we collect donor, single donor, and it goes through first centrifugation where we separate the blood, and then we go to the second separation where we get three products, which is the red blood cells, the platelet concentrate or platelet, plasma poor platelet, and plasma rich platelet. The blood safety is quite an important, and there is a lot of concerns about the blood safety. And whatever blood we do, whatever test we do as being recommended by WHO or the American Association of Blood Banking, of all these viral and protozoal infections, still, as you can see, this is the recent data from WHO shows no blood is completely zero of viral infection. We may reduce the incidence of having the infection to 0.002% in high-income countries where the infection and the quality of testing is high, or it can be up to 0.7% in some of the low-income countries. So we have to keep that in mind, because this is one of the major complications that may happen to the patients, and it's one of the drive where we ask not to transfuse unless there is a need for transfusion. When to give a blood, that's a clinical decision, and that clinical decision should put in mind not only the need but also the expected complication. Symptoms of anemia is one of the drive for transfusion, but if we can solve this with substitutions, and talking about substitution, not only the blood substitution but also the adjuvant substitution like iron supplements, B12 supplements, folic acid supplements, if we have symptoms that allow us to do that, then we would prefer to do that rather than give blood transfusion. Signs of ineffective erythropoiesis, which means that the production, even if you give the iron or if you give all the elements, will not be enough. So in that situation, you will be forced to give a blood transfusion. But you need to know how much level of the hemoglobin that you need to achieve, so you don't over transfuse and cause more complications. Bleeding, we don't transfuse in bleeding now. With the current availability of most of the factors, we minimize the transfusion of FFP, and as I mentioned, infection, we use the GCSF or others rather than the granulocyte, except in a special situation. If we go one by one through the blood products, the whole blood, I just wanted to highlight that the fresh whole blood was an old practice which we stopped it long time, but now it's coming back, and coming back for many reasons. Trauma is one of the reasons. I will not go in details about it, but I would like just to highlight that fresh blood in patients less than 2 years demonstrated decreased blood loss in pediatric population, and may be considered, especially in complex situation where the patient have lost all the blood components. Red blood concentrate, which is available in most of the hospital in different preservatives that make it 21 days, 35 days, or 42 days. For you in neonates, we don't go in these. We usually prefer to have a fresh blood within less than 7. Even if it is preserved in 42 days, we don't allow that, and particularly that because the patient cannot tolerate any increase in the potassium in the unit that can cause the hyperkalemia and cause all the complication. Compatibility is an issue with the red blood cells, and we stress on the compatibility because you may have a problem with the compatibility in neonates, especially when there is no enough testing being done to explore the presence of transferred antibodies from the mother to the baby. And we know that the antibodies can still continue in the baby for some time until it decreases or cleared from the system. The usual pediatric dose of 10 to 15 is more achievable to achieve 2 to 3 grams per deciliter, and in patients with thalassemia, as I mentioned, which may not be a case in neonates, we need to keep a higher blood because of the hemoglobin F, which is of high O2 oxygen affinity. The compatibility is an issue, and we need to be sure that the blood transfused to the neonate within the acceptable compatibility, and phenotype the baby and phenotype sometimes the mother to see if there is a discrepancy, and try to select those who are compatible phenotypically and compatible by testing. Leukoreduced is a mandate. We need to filter all the blood products because that can cause the cytokinemia, and again the neonates cannot tolerate the cytokinemia, and as I mentioned, it should be a fresh blood less than 2 weeks, ideally less than 7 days. If patients who have a history in the family of IgA, we prefer to give IgA deficient, or in patients with IgA deficient plasma infant, we need to give a washed blood where we remove most of the plasma, so the anaphylaxis cannot be happening here, and irradiated in some situation can be used. Platelet concentrate is important. We with the availability of different type of platelets, single donor or maximum donor of platelets, we need again to look at the threshold, when to transfuse, what type of transfuse, and what is the dose of platelets. For fresh frozen plasma, we are trying to avoid fresh frozen plasma by using the coagulation factor concentrates, yet sometimes we need to go for that if we have patients who have DIC, or there is an exchange of massive transfusion. As I mentioned, granulocyte is the least used, and it's only available in very tertiary center where it needs to be supporting bone marrow transplantation or patient with severe infection. The pharmaceutical blood substitute, there are many, and every day we have a new substitute. Most of the plasma coagulation factors are available from fibrinogen until factor 13. Recombinant factor 7 is available, prothrombin complex and solvent detergent plasma and albumin. All these available will minimize the use of a direct transfusion from direct blood components. Finally, the 2 points I would like to highlight is the neonatal transfusion is a new coming focus of the transfusion, and as you can see, this is the British Blood Transfusion Society new guidelines, which I would recommend that you go through it because it has a lot of information. Although the optimal hemoglobin level, as they had reviewed the literature, it's not yet been defined, and we lack the enough data to support the use of optimal. But what we learned from their guidelines, that data suggests an increased risk of brain injury, 12% versus 0 for those with lower transfusion at lower hematocrit transfusion threshold compared to the higher trigger. Another study had confirmed the same finding. Untreated anemia has been associated, as you all know, with motor growth and cognitive delay. So we need to keep eye on the hemoglobin and raise it. If it's not raised by the hematinics, iron, B12, and folic, we need to support that with the blood transfusion. In surgical patients, decreased post-operative mortality rate was associated with in patients with pre-operative hematocrit of more than 40%. This is again from the guidelines. It showed a different cutoff, which was adopted by different guidelines. And because of the sake of the time, I would like to skip that and move to the last 2 slides, which are the adverse reaction for transfusion in common and in neonates. Lifelong transfusion, particularly for patients with sickle cell or patients with aplasia or bone marrow failure, especially those who born with bone marrow failure, congenital bone marrow failures, get exposed to a lot of transfusion. As a consequence of that, alloimmunization happens, and they develop antibodies at different antigens and make the transfusion more difficult and complicated. So we would like to to prevent this by doing early phenotyping, and phenotyping match not only compatibility by the testing but also compatibility by phenotyping. Non-hemolytic transfusion reaction is one of the complications. TRALI is not common in neonates, but it's more common, particularly if we are using blood products coming from females donors, where they have exposure to the antigens and forming the anti-HLA antibodies. Allergic reaction is quite common, and particularly it happens with patients who get exposed to plasma products, both the platelet and fresh frozen. Febrile transfusion reaction is quite common, and that can happen more frequently for patients who receive unfiltered blood, where the cytokines transmitted to the patient and increase the temperature. And finally, the platelet refractoriness, which is a consequence of multiple platelet transfusion and result in unresponsiveness to platelets. All the viral infection is continue to be a risk. As I showed you, the risk is quite small, but it's there and need to be kept in mind, and surveillance should happen. And finally, particularly for neonates, red blood cell transfusion can be associated with necrotizing enterocolitis, retinopathy, intraventricular hemorrhage, and iron and volume overload. All these needs to keep in mind and try to prevent it rather than expose the patient to the complication. With that, thank you for listening, and back to the podium.
Thank you, Dr. Tariq, for this nice presentation. Though we have still time, so we'll go for the next speaker, Dr. Jibara. Dr. Jibara is a well-known neonatologist in Saudi Arabia, actually, and everywhere. Hard worker and famous. She's a director also of Saudi Neonatal Resuscitation Program, and she is a consultant at King Khalid National Guard Hospital in Jeddah, and she is a member of American Academy of Pediatrics. So, welcome.
Thank you very much for the moderator for introducing me. It's my pleasure to be here. I have one disclosure. I will not talk about resuscitation. So, what is the topics? Just put it there. Okay. So, I'll start with a case. So, we have this baby girl who was born to a mother, gravida 4, para 3, born at term by spontaneous vaginal delivery. It was through meconium still liquor. Her Apgar score was fine, 8 and 9. Her cord blood gas was also fine. So baby sent to the normal nursery. At 2 hours of age, they called the fellow on call because the baby had cyanosis and oxygen saturation was 80 to 85. She was started on nasal cannula, 2 liter, but oxygen saturation was remained the same. So shifted to high flow nasal cannula, 100%, and that did not make any difference in the saturation. Further dip in the history, antenatal nothing, there is a positive consanguinity, first degree cousin. She had one of her siblings who died at 8 years of age, labeled atrial palsy, secondary to hypoxic ischemic encephalopathy. And other 2 sibling boys who are doing well, and they are at school. In physical examination, the baby was well looking, not a respiratory distress, there is no dysmorphic feature, her growth parameter all within normal, her chest examination clear, her cardiovascular examination also normal, abdomen, other examination, neurological examination, everything was normal, within normal. So, you have a blue baby and this is not unusual for in ICU. So we have a lot of differential diagnoses. It's called, number one, the fellow kept in their mind is cyanotic congenital heart disease, could be any of like a TGA, tetralogy of Fallot, pulmonatresia, or respiratory, could be RDS, PPHN because she born through meconium still like pneumonia, or other structural respiratory problems. Could be metabolic, hypoglycemia, other important area of metabolism, neurological, and as any baby coming in ICU, one of the differential diagnoses is sepsis. So, what you will do for this baby? Full-term baby, 2 hours of age, cyanose, baby look normally well. Any suggestion? Any suggestion? Anyone? What you will do for this baby?
This one need admission first, and then we'll do chest X-ray and echo. If it's
Okay.
echo not available, at least we'll do CCHD.
Baby born 4 in the morning. So first things, it's chest X-ray. X-ray done, as you can see, really nothing significant can explain that. Lung look normal, heart size is normal, everything look normal, and this is a normal chest X-ray. So what you will do next?
Echo.
Echo. Before echo, blood gas. So this is her blood gas, 7.5, and BCO2 21, BO2 86, bicarb almost 17, base deficit 0.6. And this is on admission without oxygen. And after they start the baby on oxygen, of course, because the SATS was not improving, so they put that baby to 100% oxygen. And the gas done after almost half an hour, and you can see the gas, 7.5, BCO2 28, BO2 289, and base deficit, bicarb almost 16, base deficit -3. They did, of course, a CBC, hemoglobin 18. This is the baby hemoglobin, white cells 10, hematocrit 54, platelet was normal. And the cord gas show hemoglobin of 19.6, and the rest was normal. CRP negative. So what next? Okay, so echo was the next. So the fellow called the cardiology at 6 in the morning, and they came, and echo showed only small ASD. Blood culture, of course, taken, and baby started on antibiotic. So I came in the morning, and everybody was really, all the team around the baby. A baby sat 80s, while in 100%, and echo normal, X-ray normal, CBC normal, everything is normal. So when I came like all our neonatologists. One of the special characteristics of neonatologists, they are smiling all the time. All the neonatologists. I never see a neonatology who's يعني مكشر دائما. So I came in the morning, but my fellows, they think me like this. I came with a bomb. So everybody's scared from me actually in the unit, resident staff. And I looked at the baby. The baby looked like this. This is not our baby, but similar to. Very comfortable baby, not in any respiratory distress. So, what you should do?
Yeah. Excuse me, Dr. Jubara.
Yes.
In the blood gas, what is the methemoglobin?
Yes. This is what happened. So, when I came, I told them, show me the blood gas, and you can see
Yes.
the methemoglobin was 28.
Yeah, so methemoglobin.
So, we thought most probably this is a methemoglobinemia. But there is something. As neonatologists, we are looking for the details. This baby diagnosed as HIE, and she died with severe neurological disturbance. So I went back to the medical file, and baby born in one of the hospital referred to us to cardiology clinic. I 5 weeks of age, and according to the note from the consultant, admitted because of cyanosis. Okay, improved, but she stayed, an echo done, and it showed ASD only. Baby was stay in the NICU for 10 days because of jaundice, require phototherapy. But you can see that the doctor noted the baby had a peripheral cyanosis during crying or during feeding. But she was thriving well at that time. Repeated echo done, and it was showing only ASD with left to right shunt. So they give her a follow-up. And this is the report of the echo in the birth hospital, were done on day 1 of life. So the baby most probably was cyanosed. That's why they called the cardiology at day 1 of life. So, and the same, it showed only ASD. Then, baby seen at 4 months of age in the cardiology clinic for the follow-up of ASD. And the fellow reported there is an increasing tone in all limbs and more in the lower limbs, fisting of the hand bilaterally and scissoring. And the baby was not growing. She was failure to thrive. So what he did, evaluation for GERD and referred to neurology. And our colleagues in neurology, they like the word HIE. So they did an MRI showed brain atrophy, and they labeled her from age of 6 months as CP secondary to HIE. I looked to the file. Myself, I went to medical report. I looked to all the file. Unfortunately, no blood gas done for this baby because she was following for failure to thrive, the neurology. I found 2 blood gas at age of 7 years. And that showed the methemoglobin was 11 and showed 9.6. So most probably, this baby is the same having methemoglobinemia. We looked for the other sibling. The other sibling was doing well according to the parent, and they are at school. And there is only following in the primary clinic because they don't have anything of concern. But those 2 babies born in our hospital, and part of our blood cord gas, we do the methemoglobin. And their methemoglobin 1.7 and 2.3. And that's above normal range. So we sent a target gene testing for this baby, and it confirmed autosomal recessive methemoglobinemia with novel, not reporting mutation in the cytochrome B5 reductase. And most probably, this is a type 2 because it involved neurological abnormality. So what we did for this baby, we gave her immediately methylene blue. First of all, I consult our hematology, and the first thing they said, we never saw any case of methemoglobinemia, it's just in the exam. So we quickly review all the references and what we need to do for this baby. So methylene blue, 1 milligram per kg given, and within 10 minutes, the saturation increased to 100%, and the baby was pink. And we did a gas in 1 hour, and methemoglobin dropped from 29 to 2.8. Then we started also on ascorbic acid. We kept the baby 10 days in the hospital to see at what time the methemoglobin may be elevated. So about 10 days of life, her methemoglobin was more than 10. And from literature, we agreed this number we need to treat. So we give her methylene blue, and it dropped significantly to 1.2, and we discharge her. We bring her to the clinic in 10 days to see, and in these 10 days, almost the methemoglobin approaching the 10, and she required methylene blue because she was following in other hospitals. She went in other cities, so we refer her to our colleagues from Al-Qunfuda, and we give them advices, and we make sure the methylene blue is there. She requires several visits and several administration of methylene blue. We did, of course, hemoglobin electrophoresis, and which was reported as normal, and G6PD screening was normal for her. So this is a case of methemoglobinemia. We know it in the exams, we read about it, but unfortunately, it is undiagnosed in most of the cases. So Congenital methemoglobinemia is a very rare cause of cyanosis in neonates. It is best described by increase the sustained concentration of exocytosed hemoglobin, and that either due to congenital change in the hemoglobin synthesis or functional deficiency in the enzymes, like what happened in our baby, which is responsible for reducing methemoglobin in the normal erythrocyte. What is the normal? In general, anyone who did the methemoglobin, it should be less than 1%. So this is showing us, like, as you can see, let me just see, yeah. The hemoglobin molecule is a tetramer, two molecules of 2 alpha and 2 beta. And each of a hemoglobin molecule will have 4 atoms of iron, which is a ferrous form. And that can reversibly link to the hemoglobin and link to 1 molecule of oxygen. And that gives you a 4 molecule per 1 hemoglobin molecule. If there is a problem, like an enzymatic deficiency, like in a case of cytochrome B5 reductase mutation, or the commonest is during drug-induced methemoglobinemia, what's happened? The ionized form of hemoglobin, where the ferrous hemoglobin will exodize and it will go to the ferric. Okay, ferric iron. Ferric iron cannot bind to oxygen, so it will increase the oxygen, the affinity, and lifting the oxygen dissociation curve to the left. And that's what will happen, what will cause, that will affecting the release of oxygen, leading to tissue hypoxia. Other mechanism or other causes like abnormal hemoglobin, that's why we do hemoglobin electrophoresis in the babies, or other causes to rule out other associated hemoglobin abnormalities. How common this? When I look to the literature, in 1845, a French physician described a patient who endorsed as a congenital cyanosis, and that baby had any obvious cardiac or pulmonary dysfunction, so they call it congenital cyanosis. In 1940s, Gibson showed that in this patient there is a diminution in the ability of erythrocyte to reduce methemoglobin. In 1959, they identified the enzyme responsible for methemoglobinemia, which is the 5-alpha cytochrome B5-alpha reductase. How is the incidence? Really, the incidence is unknown, because most of these cases misdiagnosed or labeled as, for example, HIE, especially the one who will have type 2 with progressive neurological disorder, and they died early in life. So I found this portrait in 1982, and it's written blue-skinned Fouquet family. So a family like lived in 1700 with a father called Martin. He was blue. Then he get married to a lady, which was supposed to be normal, and they have 3 kids who was blue, and they label them as the blue family. And there is a root of different pedigree for those without, of course, diagnosis, but they call them the Fouquet family. So congenital methemoglobinemia is really underdiagnosed. When I looked to the literature, I could not really find any really detailed cases. So this is one of the reports in 2017 in hematology journals by the American Society of Hematology, and they report only 11 cases. And these cases, if you can see, with very high level of methemoglobin, But actually, most of them didn't have really an accurate diagnosis. So, in some literature, it has been estimated 1 in 100,000 cases. But a paper from Russia, they reported 47 per 100,000 cases, with high prevalence in that area. What about in our Kingdom of Saudi Arabia? I looked actually, I could not find any neonatal cases has been reported, except these cases by our colleagues, Dr. Manal Jilwan, I think, hematology, from radiology, department. They reported a baby with hypoplastic basal ganglia, and when they do extensive workup for developmental delay, they found she had cytochrome B reductase deficiency, and that confirmed the diagnosis, but unfortunately the baby died. She had another one sibling with the same family, delivered in another hospital, referred to King Faisal Specialist Hospital because of the methemoglobin was 25, and they start immediately methylene blue, and follow up at 3 months. She presented with seizure, and MRI showed abnormalities, and genetic testing confirmed type 2 congenital methemoglobinemia. This is a case report also from Saudi Arabia, but they didn't have a genetic diagnosis. It's a 16 years old who presented with cyanosis, and when they did the methemoglobin, it was 27. It was high, and they did the cytochrome B5 reductase, and it was low, but no genetic testing, and the patient disappeared from the clinic, and there is no follow-up for that one. So this is the only reported, I found it in the Saudi Arabia. So the form, the commonest one, and you find a lot of report, is related to drug exposure, and this is an acquired, and presentation of cyanosis happen in most of the time in adults, and there is some cases of pediatrics. The type 1 methemoglobinemia, which is autosomal recessive disorder, presented all the time with cyanosis at birth. Type 2, the same gene, but the presentation the same as type 1, but unfortunately they have neurological involvement, and it's bad and poor prognosis, unfortunately. Type 5 or 4, very, very rare. I could not find except only one case report, and they presented with disorder of sexual differentiation and cyanosis at birth. Now, and there is another like hemoglobin M disease and unstable hemoglobin, and those autosomal dominant disorder, and the gene identified, and the same they presented at birth with cyanosis. This is the commonest, and if you look to the literature, just if you put methemoglobinemia, what will happen is the acquired one, and there is 126 medication can cause methemoglobinemia, and this can be treated most of the time easily. So the type 1, the problem is the functional deficiency of the cytochrome B5 reductase in RPCs. They have high methemoglobin, and up to 40%, but the babies usually they adapt to high level by compensatory polycythemia, and usually they have normal life expectancy. Type 2, as I said, a rare one and severe form, and the deficiency in all types of cells. Life expectancy is short, and most of them, they will die in the infancy. Affected newborn usually presented with progressive neurological deterioration, mental retardation, developmental delay at early age, at 3 to 4 months of life, and death usually happen within the first few years of life.
2 minutes, Doctor.
So, 2 minutes, okay. So clinical presentation, it depends on the level of methemoglobin, less than 10, asymptomatic, and more than 10, cyanosis, for bigger or adult, they presented with headache, fatigue, dyspnea, lethargy. More than 70 is associated with high risk of mortality. How we can diagnose this? First of thing, you can have a quick bedside. The blood of babies with methemoglobinemia, it will be brown chocolate color, not red like other. And this is really what we notice when we extract blood. The blood look brown. So what you can do, you can put a 1 drop in filter paper and you can see the color. It will not change when exposed to oxygenated, to the room air. While the normal blood, it will be red color. Cytochrome B5 reductase activities is very important to establish the diagnosis, but in neonate, only 50 to 60% they have a normal adult level, and did not really till age of 12 months to have the adult range. And most of the lab, they didn't do it, so we were not able to do it. Even when we tried to send it to Germany, they said we didn't do that. So the genetic testing, I consider it the gold standard, and it should be done for all babies, especially if there is a family history. Hemoglobin electrophoresis is important to rule out the other abnormal hemoglobin, and G6PD screening is important. Management, if you look, there is really no recommendation at all what we need to do for those babies, and even the treatment will help or not, especially for type 2. So several factors depend on the patient symptoms, total amount of methemoglobin, the cause, and the patient age. And if he had additional compromising risk factor like congenital heart disease, lung disease, or significant anemia, the drug of choice is methylene blue, and it is a magic. Within minutes you will see the response, and it can be repeated. The problem with it's contraindicated with baby with G6PD deficiency. And ascorbic acid, another one, can be used as adjuvant therapy. It's a strong reducing agent that take part in many oxidation reduction reaction. Nobody knows what is the exact dose. A lot of doses has been reported and can be used if methylene blue is contraindicated. Hyperbaric oxygen used in adult, but there is no data for neonate. And exchange transfusion has been suggested, but again, there is no data for neonate. So, in conclusion, congenital methemoglobinemia is a very rare condition. If you have a baby with a cyanosis without respiratory distress and no cardiac abnormality, it's methemoglobinemia till proof otherwise. In neonatal population, treatment should be started early, but due to limited compensatory capability in the first month, prognosis, it depends on the type. Type 2 is the bad, very poor prognosis, while type 1 is normal. And thank you very much.
Thank you, Dr. Jabara. Inclusive and detailed the presentation. Thank you. The next speaker in this session is one of our colleagues, friend from other department. But before he come to the podium, I want just to prepare for his lecture by saying that this lecture was supposed to be given by me. But I said, there is some better people from the legal point of view, they can, do better presentation and maybe put you in a better way of looking at this matter. The work we do as a neonatologist is very complex work. We are really dealing with very sick babies with, a lot of debate about viability, viable, not viable, what to do. So it's a lot of big questions that, usually we dealt with it in our clinical practice. And to treat, not to treat, to do C-section or just leave the baby in till, born as a stillborn, to do full support after birth or just to do comfort care. And if we start treatment, what we will do after? Should we withhold advanced treatment? Should we withdraw the treatment? So all these questions over years, and every presentation, every time we meet together, we try, to bring it up. But I think in my, simple and humble conclusion, that I think we need to communicate more. with the obstetrician. Of course, as you know, they are the one who will handle those babies to us. Communication in prayer time, and and also to be involved more with the parents, to discuss with the parents, and not only to discuss with them before delivery or with acute incidents, what happened to the baby, to communicate with them on ongoing basis what's going on and to update them. And in spite of that, you will find some families, they still complain, and they will complain about you and said you didn't do a good job. So I think the medical legal issue is there for a long time, but it may increase with what's going on in the society. It's a pleasure to present to you Dr. Abdul Hamid Al-Saeed. Abdul Hamid Al-Saeed graduated from King Saud University 1982, and he did his fellowship in anesthesia through the Royal College of Surgeons of Ireland. He's currently a professor of anesthesia and the chairman of the cardiac anesthesia division at King Fahd Center at King Saud University. He is the chairman of the Saudi Anesthetics Association from long time till now. So, and he's a consultant anesthetist in King Khalid. What is important in his career, he's an advisory consultant in Ministry of Health for the medical legal cases since 1998. And this is what make him a good resource for a lot of medical legal cases that he saw during his career and participating in this committee. فدكتور عبد الحميد تفضل.
بسم الله الرحمن الرحيم. Thank you very much, Dr. Abdul Hakim. It's my pleasure to be with a neonatologist. I deal with the cases on neonates as an anesthetist, but today my talk will be about medical legal aspect, because none of us is immune against medical legal. Any parents can, as Dr. Abdul Hakim says, can complain against you. So this lecture is, I hope, in 15 minutes, just show you, as you can see from the past history, even the people at the back here are waiting with the papers. They are medical legal people, waiting for any mistake to happen. Let's talk about the scope of the problem. We have upgrading technology, as Dr. the one before me mentioned, that is a lot of technology coming. A lot of people coming from abroad, training with experienced medical staff. But the same thing, the population census started, the social media become very awareness of about the health matter is very important. This is some of the upgrade in the hospital. This is robotic surgery in cardiac surgery. So there is a lot of development, but at the same time, thank you very much. At the same time, you will find in the social media or in the newspaper like this cartoon, أبدا والله كل اللي حصل مجرد أخطاء طبية بسيطة. So the people will get that the people in the hospital coming to make a mistake. Or like this one, الصحة تناست القضية ولدها في حيرة تخدير تشيل طفلة رهف الطبيب هرب إلى بلادي دون حساب. Big picture in the newspaper, people will get worried about their children and their patient. This is one of the newspaper. الرياض أصدرت الهيئة الطبية الشرعية منطقة تأسيس وحكم بتغريب طبيبين مستشفى خميس مشيط 120,000 ريال تسببهما في غيبوبة مريضة لمدة عامين. Like this newspaper, like this خطأ طبي يؤدي لقطع لسان طفلة وآخر يوم يا أخاها. عفوا. Like this picture, they put this الخطأ الطبي حرم خالد وأحمد وريناد من والدته. Her mother died, so they put the picture of the people that. So to handle the problem of the medical legal committee, they formulate standard and regulation related between the facility and the physician towards the patient. And this was incarnated by Royal Decree 1409 هجرية. From that time, it's becoming responsible, determine responsibility of medical practitioner, regulate the patient-doctor relationship. So anybody cannot go and fight with the doctor in the hospital. You have to go through the medical legal committee. The members of medical legal committee usually is the judge, which is assigned by the Ministry of Justice. He is what we call فئة ألف, قاضي فئة ألف, and doctors from 2 members. We meet every week. As you can see, this is the judge and the papers of the file of the patient in front of him. Okay. So this is the guy is the legal advisor. He's a urologist. The next one to him, and then general surgeon, and then me, and then the judge. In the other side of the table is the people who are complained against. They are talking, and medical legal committee, we have the rule. It's responsibility of the receiving claims, investigation, professional malpractice, and relate either to morbidity or mortality. Number of the 8 subcommittees is becoming now more and more. I heard the last development that's become through the محكمة الشرعية. You have to go to the محكمة الشرعية, but we used to be in the. So what's the process usually? The claim from the patient was his representative towards the medical practice from his view that it's a mistake happened. The claim directed either to Ministry of Health or city government. Investigation start immediately within the medical facility. It will take time, but usually the file will be stopped, will be kept secret places, and investigation through the hospital. The medical legal committee assigned then to follow the process through and then they will reach to the final decision, which is according to the Sharia medical practice, Islamic Sharia. So for the female, and don't get angry from me, usually بالنسبة للدية الشرعية نصف دية الرجل. This is just some professional civil liability, مسؤولية المدنية, punitive liability, مسؤولية تأديبية. مسؤولية المدنية is the responsibility of the physician towards the patient when harm being inflicted as a result of direct. يعني إذا حصل شيء للطفل أو للمريض هذا تعتبر مسؤولية مدنية. مسؤولية الجزائية physician who violate the rules and regulation of the medical practice even with no subsequent harm result. والمسؤولية التأديبية when physician fail to meet the professional requirement of ethics. يشتغل بدون ترخيص من الهيئة السعودية الصحية الشرعية. كان لوكم. The final decision will reach in the committee either clearance from the claim, and this most of the cases, or warning to the doctor, financial compensation to give to the patient relatives, or prohibit the doctors from medical practice, medical license withdrawal, and we can put the doctors in the prison. This has never happened, alhamdulillah, so far. This is some studies which I did it in 5 years, just to show you how, and it's published in your King Faisal journal. The aim of the work is to study the period of the analysis, medical specialty, which have the more medical mistakes, and sector of the healthcare facilities, and geographical distribution of the kingdom. And as you can see by the years, it's becoming more and more claim. As I said, upgrading hospitals, same times people with the social media, they are becoming very famous with the newspaper, with the Twitters. They can simply just mention the accident and you will find it spread all over. I found from my study that most of the cases is obstetric and then the last one is dentist. Obstetric, I think, because of the mother and the baby. If the mother is saved, the baby may be not saved. So that's why the obstetric is more. Percentage of the trend malpractice, total number, as you can see in 1420 was the highest, then it became less and less. But this is just to show you how distribution of medical health care service. Ministry of Health, most of the cases happen with it. In 1424 was 188 compared to other medical services, because this does not blame Ministry of Health, but because most of the Ministry of Health care about 90% of the health care in this country, where National Guard is only for the National Guard, university only for the university, security only for the security. So private only, military for, so that's why Ministry of Health does not mean it's bad, but because it is, mostly of the cases happen in Riyadh, then Makkah al-Mukarramah, then Eastern region, then Medina Munawwara, then Asir, Qasim. Ihsa was, subhanallah. Just to give you some example, which Dr. Abdul Hakim said, I'm an anesthetist, which is anesthesia-related malpractice. Just to show you some example. This is morbidly obese patient, was coming for elective gastric bypass surgery. No concurrent illness, preoperative fasting for 16 hours, proper medicated, and then aspiration prophylaxis was given. But the anesthetist did the mistake that he used a long-acting muscle relaxant to start. In this case, it should be rapid sequence in order to protect the airway. So he used cisatricorium. He first attempt endotracheal tube, then 15-minute refractory hypoxemia. He postponed the surgery, transferred the patient to ICU. He had multi-organ failure, and then mortality followed up. The anesthetist was accused of not being following the medical standard of not using short-acting muscle relaxant during intubation, especially for the obese patient. The other case, this is a female, para 11, for emergency cesarean section, breech presentation. There was a lot of hemorrhage intraoperatively. No blood was available. 6 hours postoperatively, mortality follows this lady. And the husband, of course, get another wife. The anesthetist shares responsibility with the obstetrician for not checking the blood availability, or even reserving a no intraoperative anesthesia record of management. The last case, diabetic patient for emergency perianal abscess evacuation. Preoperative blood sugar was 235 milligram, and then they started her on insulin. The surgery was very minor, uneventful, continuous and normal saline postoperatively. They never checked. The patient started to have disturbed consciousness, severe hypoglycemia, cardiorespiratory arrest, and mortality for 5 days in the ICU. So the anesthetist was accused not following the standard medical practice for checking the blood sugar postoperatively. So from 15 years in this medical legal, the recommendation, which is a home message for all of you, as you can see, there's no minor anesthesia because I'm an anesthetist. Also for you, there's no minor neonates. Always should be. Assess your patient thoroughly. Ask for advice in case you need. One of the cases happened that the anesthetist was نافق صدره شوية. قال له I don't need the help. I'm a consultant and I will call another consultant. What's the point? So if you are in trouble, call for somebody help, for another opinion. Share the patient and relative plan of treatment. Always very, very important. Most of the cases, the patient does not find the doctors to talk to him of what's happening to his child or what's happening to the patient. So it's very important for you. Estimate the accuracy and discuss with the patient. Always make clear consent, informed consent, and clear documentation of every detail, date, time, very important. Most of the doctors who was cleared from a complaint because they have record and date and time, they have explained to the patient what happened to him. Encourage your education activities by attending like these meetings. Update your professional knowledge. In case happened to you an incident, as I mentioned at the beginning, none of us is immune. Review the case, filling records, quote relevant literature, provide testimony in writing, and don't fight with the people in the judge, in the court. Fighting means that you are not trustable. This is my opinion, I think. We'll have it. So be quiet, writing everything in document. When you are certain of consequences and error disaster, so it's logic to be too careful. No one is immune against spiteful mischief, and we pray for Allah to provide us. This is from Iraq picture. This all children is being killed by American terrorists. To whom they should complain? I mean, when you have a mistake in the hospital, they will go and complain against you as a doctor. But these children, whom they should complain? Thank you very much, Dr. Abdul.
شكرا دكتور عبد الحميد. I'm sure you have a lot of questions in your mind about how this committee, the medical legal committee of the Ministry of Health work, and we will have an open discussion with Dr. Abdul Hamid after we finish this session. We have one more lecture in the session. Dr. Abbas Al-Amran, who is a consultant neonatologist in Al-Mani' General Hospital, Al-Hasa Al-Hafuf. He's graduated from King Faisal Dammam, 1987, Arab Board in Pediatrics and Fellowship at King Faisal. And Abbas well known for his activity and interest in the bilirubin. He will talk to you about red flag in hyperbilirubinemia. تفضل عباس.
Thank you very much. Just give me a minute, please. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد وعلى آله الطيبين الطاهرين وأصحابه المنتجبين. Good morning everybody. Thanks for the organizing committee for inviting me to give this presentation. Actually the title was Red Flags on Indirect Hyperbilirubinemia, but it happened that the American Academy of Pediatrics published an update on their guidelines on last September, 2 months ago. So I elected to put them both together, the update and the red flags together. I'll start with this case. This is a tragedy that happened like 10 years ago, and I think it's still happening. This baby was born at 39 weeks with appropriate for gestational age weight, and the mother was healthy, gravida 2, para 1, 32 years old, and the baby was discharged as a normal baby at 25 hours. And if you look in here at the picture of the graph here, I can use the pointer. Our protocol in nursery that we check the bilirubin every 8 hours. We screen the babies for jaundice, and actually we assume that babies are G6PD deficient even before we have the results, because we have high incidence of G6PD deficiency. So that's why the red color, the yellow color pointing that this baby is having risk factor that is assuming to be G6PD deficiency. So the baby was discharged and came back after 4 days to the OPD at around 100 hours of age. And I admitted the baby in the evening. That was around 8 o'clock in my evening clinic. And I advised for starting intensive phototherapy, and I went home. Next day I came in the morning, 8 o'clock, asking about the baby, and they told me the baby disappeared. After admission, they checked the bilirubin. It was 340, and then the father received a call from his mother, the grandmother of the baby, saying that this is simple hyperbilirubinemia or jaundice that can be treated at home. So he signed against medical advice, and our residents, he did not object, so he discharged the baby. And I called the father, and I told him that you have to bring the baby. The baby needs phototherapy immediately, but he was at work. He didn't come back till around midnight, when the baby refused to feed. Baby is not feeding anymore, so they brought the baby. And unfortunately, the baby was in a bad shape. The bilirubin was 686 micromole, that's 40 milligram per deciliter. We exchanged the baby, but the end result was this baby after 2.5 years. If you look at this baby, look at him, he has chorioathetotic movements. If you look at his teeth also, he was not hearing well. So this is a case of kernicterus. So what we did in the unit, I think we did good things, that we are monitoring the transcutaneous bilirubin for every baby, and we screen for the risk factors, including the blood grouping and the G6PD at that time, and we gave follow-up. The patient came on follow-up, and we encourage breastfeeding. We educate parents. We give them materials about jaundice and G6PD deficiency and breastfeeding. And I admitted the baby on time, I think, but the problem happened. If you look at the curve again backwards, you see that we did the transcutaneous bilirubin, and it was low in the first 24 hours, so it did not help us in the screening, actually. So this baby had G6PD deficiency. We had the results later on, but we identify him as G6PD. We readmitted the baby, but unfortunately, our doctor allowed the baby to go home, even against medical advice. That's why we need to educate our medical staff, our residents, junior doctors, and we have to educate also the parents. And we lost this baby on follow-up. I needed to call him to video him again. So actually, we don't know what is the incidence of this issue of severe or critical hyperbilirubinemia and bilirubin-induced neurotoxicity or kernicterus in our country, and what are the measures that we are taking to reduce this problem. We have to work on this, as it stated this morning and yesterday. A quick review on jaundice. As everybody knows, that jaundice is very common, especially in our place. Most of the cases, they end up in benign outcome, but some of them, like 10%, they develop severe hyperbilirubinemia. They need treatment. And in 2016, there was 1,309 deaths per 100,000 live births because of jaundice. And it's ranked the 7th globally among all causes of neonatal death in the first week. So it's a global problem. It's not only happening in our country. This is a quick review on the metabolism, production, and elimination of jaundice. We need to understand that being jaundice is the outcome of increased production and decreased elimination in these babies. Classification of jaundice, I think it's important so that we talk about the same thing, but if you see severe jaundice, it's labeled as if the bilirubin is exceeding 20 milligram, and extreme is if it is beyond 25 milligram, and hazardous or critical if it is 30 milligram or more. The acute bilirubin encephalopathy is a syndrome that occurs in the first 14 days, usually with neurological symptoms in association with critical level of hyperbilirubinemia, and it can be divided into mild, moderate, or severe. And if you see here, it can reach to irreversible stage once the bilirubin is at like 25 milligram or more, depending on the postnatal age and the gestational age. The chronic sequelae of acute bilirubin encephalopathy is the syndrome that's labeled as kernicterus, although kernicterus is actually a pathological description, but the syndrome is composed of 4 items. That's chorioathetoid cerebral palsy, high-frequency central neural hearing loss, palsy with vertical gaze, dental animal hypoplasia, and characteristic findings on the MRI. Whereas the histopathology shows usually deep yellow staining of the neurons together with neuronal necrosis, particularly in the basal ganglia and the brain stem. Why are we seeing still kernicterus with all the advantages? This is really a red flag that we still see these cases. It's worldwide, but why? Mostly because babies are discharged very early without watching them carefully, and there is no post-discharge follow-up in most of the hospital. Actually, this is one major point that we have to tackle in these conferences. Poor maternal education, inadequate breastfeeding, and hemolytic diseases, particularly G6PD in our place. But overall, Maisels, who is a bilirubinologist, mentioned in one of his articles in 2015 that failure of clinicians to follow the guidelines accounts for most of cases of kernicterus. Like they don't worry about the level of bilirubin, they check it by their eyes, they don't ask for serum bilirubin. If you see this picture also, the baby is trying to say, exchange me, I have critical hyperbilirubinemia, but sometimes our physicians, they take it easy. And this is the registry of the United States of cases of bilirubin between 1992 and 2004. You can see it's increasing. I hope we can find or make a registry like this in our country. So what is our goal of treatment? Our goal is to prevent kernicterus. So our goal also is to decrease or keep the bilirubin below the exchange level that induce or what induced the neurotoxicity. And hospitals, they have to have policies to give the necessary care to minimize the risk of kernicterus. These are the guidelines that we have been using over the last 15 years, I guess since 2004, published by the American Academy of Pediatrics. On the left is the phototherapy thresholds, and on the right is the exchange blood transfusion. I found them easy to use and very useful, but there are some changes in the 2022 issue. In 2009, they made some clarification. They divide the risk factors as hyperbilirubinemia risk factors, factors that increase the production of hyperbilirubin, and hyperbilirubinemia neurotoxicity risk factors, which I'm going to tell you about later on. And after applying these guidelines, actually, the hazardous hyperbilirubinemia level incidence decreased because of two issues: the universal pre-discharge bilirubin screening and the closer post-discharge follow-up. This is the article published in September 2022, and it stated clearly here that the committee recommends caution and incorporation of local expertise in adapting these guidelines for use outside the USA. So generally we use their guidelines, but we have to have our own depending on our experience and patient type. These are the risk factors for developing significant hyperbilirubinemia. I think it is all known to you: low gestational age, early jaundice, pre-discharge bilirubin. It's a must. You have to check the bilirubin before discharging a baby if it is approaching the threshold, and hemolysis from any cause. Okay, whether it is known or suspected. Like in our patient, we suspect it to be G6PD. We assume every baby to have G6PD deficiency. If the baby received phototherapy before discharge, if parents or sibling had phototherapy before, family history of inherited RBC disorders, particularly G6PD deficiency, and suboptimal exclusive breastfeeding, especially in primary mothers. You need to support their breastfeeding. If there is scalp hematomas or bruising. And how do we decide about the need for treatment? It will depend on the gestation as well as the age specific, our specific total serum bilirubin level or the transcutaneous bilirubin, but usually before starting phototherapy we do serum bilirubin, and the presence or absence of risk factors for bilirubin neurotoxicity. These are the hyperbilirubinemia neurotoxicity risk factors that includes again premature babies less than 38 weeks. Even 37 weeks is considered not a premature baby, but a risk factor for developing severe hyperbilirubinemia and neurotoxicity. The presence of isoimmune hemolytic disease, hemolytic disorders, particularly again G6PD deficiency, and hypoalbuminemia, presence of abscess, acidemia, or clinical instability within the last 24 hours. Red flag in here about G6PD deficiency, الفول وما أدراك ما الفول. G6PD deficiency is the most important cause of hazardous hyperbilirubinemia, leading to kernicterus everywhere, not only in our country, even in America and other countries. G6PD is the leading cause for hyperbilirubinemia associated with kernicterus. These infants are more likely to receive phototherapy before discharge. They are at greater risk of readmission. If you see a baby who is formula fed, exclusive formula, and then he develops severe hyperbilirubinemia, think of G6PD deficiency. Some of them, they don't have positive family history, okay, or maybe the parents, they don't know about it. Sudden and extreme increase in total serum bilirubin is another cause. That happened to our patient, if you remember. Suddenly the bilirubin increase. And there may be little or no laboratory evidence of hemolysis. Usually the retics are normal. So that brings us to the conclusion here that neonatal screening for G6PD deficiency is a must, particularly in our area. It's an X-linked recessive disease affecting around 400 million people worldwide. If you look at the incidence here in the Arab countries, I think we had SAP here we have the highest number reporting up to 40% G6PD deficiency. And compared to Bahrain, 18, and Oman in the Gulf area, I think up to 29. So we have the highest incidence of G6PD deficiency in the region. This is a study done by Professor Al-Hazmi showing that the Eastern province carries the highest frequency of G6PD deficiency genes, especially in Qatif and Al-Ahsa area. And this is a study published in, I think in 1992 or so, done by Professor Abu Wasba and his group. And they screened 34,000 newborn in Dahran Aramco Hospital, and they found 18.4% of these babies were G6PD deficient. 42 of these babies required exchange transfusion, but none of them developed kernicterus compared to the period prior to the study where they have 7 cases of kernicterus. And they come out with a conclusion again that neonatal screening for G6PD deficiency and comprehensive education program is advisable. We reviewed the causes of jaundice in our hospital, King Fahd Hospital, before in 1999, and the same finding also we reached that 30% of our readmitted babies for jaundice were G6PD deficiency, and we came out with the same conclusion and recommendation that cord blood G6PD screening is a must. And we repeated the study later on. I think we published this in 2017. Again, around 40% of our readmitted babies were G6PD deficient. And again, we recommended G6PD screening. Visual estimation of bilirubin concentration. The American Academy recommends that you screen the babies visually, or it's better to be done by transcutaneous at least every 12 hours. What we do in our unit, we screen them by transcutaneous bilirubin every 8 hours. And the total bilirubin, serum bilirubin, should be measured as soon as possible for infants noted to be jaundice or transcutaneous bilirubin. And those who are appearing jaundice in the first 24 hours, particularly at higher risk of developing significant hyperbilirubinemia. But visual assessment does not replace the need for obtaining at least one reading by transcutaneous bilirubin or serum bilirubin before discharge. That is the recommendation. The transcutaneous bilirubin measurements are valid and reliable, and to reduce allotted blood sampling and reduce the rate of having significant or critical hyperbilirubinemia, and this can be done in nursery as well as the OPD during the visits. But we need to check the serum bilirubin if the transcutaneous bilirubin reading is within 3 milligram per deciliter of the phototherapy threshold, or if it is exceeding 15 milligram per deciliter. And if the baby received phototherapy, usually transcutaneous bilirubin is not valid until 24 hours after stopping phototherapy. You can calculate also the rate of increase to give you an idea of the rate of hemolysis if they are. Post-nursery discharge is follow-up is a must. This is a very important item that we need to really emphasize it. And I like to repeat what Egret wrote once in 1998, that post-discharge services are more important to assure good outcomes than the precise time of discharge. So whether the baby is kept for 24 hours or 48 hours or more, you still need to see these babies after discharge. If you cannot guarantee post-discharge follow-up, then maybe the baby can be staying in the hospital for close monitoring. Usually, once the spontaneous bilirubin comes down, it does not increase. So if you saw the baby at 1 week and the bilirubin is already down, you don't worry about it anymore.
Abbas will give you 2 more minutes.
Give me more, please.
لا تنسنا. Conclude. Huh?
Timing follow-up, before we use this curve in the upper right, but this is called botany nomogram, but it's no more recommended. The American Academy of Pediatrics recommends that you calculate the difference between the transcutaneous bilirubin or the serum bilirubin on discharge and the level of phototherapy, and according to the table you decide the timing of follow-up and the type of follow-up. Prolonged indirect hyperbilirubinemia. This is if the infant is 7 days or more and his bilirubin is within 2 milligrams of the phototherapy threshold. This is usually associated with breast milk, and you can use home phototherapy for these babies if they are not exceeding the phototherapy threshold. But you have to consider cholestasis in babies who have prolonged jaundice defined by breastfeeders who are still jaundice at 3 to 4 weeks of age, or on formula feed of those who are 2 weeks or more. And the new definition for direct bilirubinemia or cholestasis is when the direct bilirubin exceeds 1 milligram, regardless of the percentage, whether that is 20% or more. 20% is no longer regarded as necessary. Phototherapy, we need to use phototherapy as intensive phototherapy, and the cylinder phototherapy is the preferred method of administering phototherapy nowadays. No one, I think, use the ordinary single phototherapy anymore, or double phototherapy. There are 3 points here that the technical report advised. They say that there are new evidence indicating that neurotoxicity does not occur until bilirubin levels are well above the 2004 thresholds, and systemic review of phototherapy associated adverse effects found limited or inconsistent evidence of late adverse effects that includes cancer or epilepsy. And IVIG immunoglobulin has unclear benefits for preventing exchange blood transfusion in isoimmune hemolytic disease. This is the phototherapy threshold guidelines using different gestational age according to the gestational age of the baby. And there are 2 curves now. When there is no hyperbilirubinemia neurotoxicity risk factor, and the other one for hyperbilirubinemia neurotoxicity risk factor. So things are getting more straightforward, but it's also you are using 2 curves rather than 1 curve. The previous ones we are using 1 curve for all babies. Now that is different. I think it's easier to use the first one, but particularly this one has different gestational age from 35 to 40 weeks, so maybe it's a better curve. But I'm concerned about the level of starting phototherapy really. Home phototherapy is not possible in here. Sun exposure is not advised. Please don't advise babies to be exposed to sun. We have to encourage breastfeeding, and we don't interrupt phototherapy. Interruption of phototherapy is not a problem unless the bilirubin is really reaching the exchange. You have to screen them for a cause of jaundice. And when to discontinue phototherapy is very important. I think this is the first time they touch on this. Usually phototherapy, we started and then we watched the bilirubin falling down, but they advise if the bilirubin is 2 milligrams below the threshold, you can discontinue phototherapy. Rebound phototherapy occurs a different percentage according to the cause, but G6PD deficiency again is the main cause of rebound phototherapy.
1 minute, Abbas, to finish.
Phototherapy follow-up, you have to follow them up and check the bilirubin within 12 or 24 hours if possible, otherwise later on. This is a new phrase that they are using, escalation of care, rather than they used before crash management. Now they use escalation of care. That is the care provided for those babies approaching the exchange level when the bilirubin around 2 milligram below the exchange level. So this is considered an emergency. You have to admit these babies to the NICU, and if you cannot do exchange transfusion, transfer the baby immediately on phototherapy and IV hydration. These are the new curves used for exchange transfusion, and it's available free online. And you can use also the bilirubin albumin ratio. Immunoglobulin can be used, they say, if you are approaching the exchange level within 2 milligram. This is a new item that I think maybe inshallah in the future will be possible, that they put a patch on the forehead and check and they have monitoring, continuous monitoring of the bilirubin together with the heart rate and SpO2. In conclusion, severe indirect hyperbilirubinemia remains a life-threatening condition, and delaying the diagnosis and management is the major contribution factor for morbidity and mortality. Promote breastfeeding, please. Educate parents and physicians. Hospital policies has to tackle this problem to prevent kernicterus. We have to have our own guidelines. We have to have our G6PD screening, and we have to start registering cases of kernicterus. And again, we have to have post-discharge follow-up. Thank you very much.
ثانك يو عباس. شوي ونطلب لك السكيورتي بس عاد كويس. خلصت الحمد لله. حفظك الله. تسلم. Okay. Can we have the speakers here on the podium? Please. So we have some time for discussion, and if you have any questions, put your hand up. Introduce yourself. Professor Khalid Al-Falih. Let's start. And I will introduce you. طيب. تفضل بروفيسور.
يعطيك العافية. شكرا جزيلا. Thank you so much for all the speakers for very enlightening presentations. And I have a comment regarding jaundice. I think severe jaundice and kernicterus should be a priority for the Saudi Neonatology Society guidelines and policy development in the near future. This should be addressed immediately, and we should look after this problem as soon as possible, because it is a big problem. It is common, and kernicterus is 100% preventable, as we all know. My questions to the speakers and to anyone who knows. We in the private practice, regardless of the hyperbilirubinemia, we face a lot of parents making decisions on behalf of their babies to go home against medical advice, which put their babies at risks of complications either at home or just because of lack of medical care to their babies. Are you aware of any laws in Saudi Arabia that can protect those babies from the wrongful decisions of their parents? And if not, can we ask the Saudi Neonatology Society to communicate with the Saudi Human Rights Commission to develop such a law to prevent parents from making the decision to go home against medical advice? Thank you so much.
For this question, any volunteer to answer?
I don't have an answer.
Yeah, but try to have a short comment about the comment of Professor.
Yeah, definitely we have faced a great problem, as you mentioned, and I demonstrated the case. We lost this baby because of the parents or the grandparents. So we have to have something against this. But I think also we have contributing part. I mean, if a physician sat with the parents and explained to them fully what are the consequences, maybe they will change their minds.
Maybe I comment on that. I do it in a different way. Like, there is no discharge against medical advice for nursery at all in our hospital. And if we are like calling the social worker, calling the patient relation. Number two, if they are insisting, we ask them to go to نقول لهم روحوا الشرطة وجيبوا أمر بأخذ الطفل. I did that for 5 patients, and all of them, they said, okay, keep him. So I think jaundice, as you mentioned, it's a very bad actually, and it's affecting a normal babies. So we need to work very hard, have a consensus about discharge against medical, maybe other problem like follow up for something else, يعني borderline, but jaundice we should take it very, very seriously. Maybe for a recommendation from the society about jaundice management as a recommendation, I mean out of the meeting, توصيات تخرج من الاجتماع, how to deal with jaundice and the recommendation. Number 2, we did very excellent things, which is creating a jaundice clinic every day, even the weekend. Any baby discharged from normal nursery, he will come 24, 48 hours according to the risk and according to the graph. And it's surprisingly, even low risk baby, they come within 48 hours with high bilirubin require phototherapy. Alhamdulillah, like more than 10 years we're creating this clinic, we didn't have any exchange transfusion. But keep in mind, even low risk baby, they may come with really high jaundice in the intensive photo.
Excellent. طيب تفضلوا دكتور سعد, Professor Saad.
I just comment on what the Prof. Khalid Al-Falih said. Is really discharge against medical advice is a problem, and unfortunately, most of the hospital they have guidelines for discharge against medical advice, but general does not address discharge against medical advice for the minor, like our babies, except few hospitals. I think I agree with Prof. Al-Falih that we need to address that, either we as a society or through what they call the Saudi Council,
Can we, Professor Saad, can we hear from Professor Abdul Hamid about what happened, like, if some case like came with this signature of the family that they signed against medical advice and something wrong went to the patient?
في الحالة هذه ما يتحمل الطبيب أي خطأ. إذا كتب البيرنتس إنه موافق على خروجه ويتحمل الخطورة، القاضي دائما مع الحق، يعني ما.
So it's part of the legality that, if he signed, then this is their responsibility. But our colleague here, they want to be advocating for the patient themselves, the right of those patients. I think it's worth it, to discuss it and see if we can bring it up to a higher level about what to do.
Yeah, I think the aim is to protect the babies. It's not to protect also the physician. They can't sign and go, but our aim is to protect the babies. So signature is not.
Of course.
The other thing may be the involvement, the SCAN team, the child abuse and neglect in the hospital. If any parent came for discharge against medical advice, especially in jaundice, involve that team. Each hospital in Ministry of Health, and they have that team. I think involve them, it will make a difference also.
طيب good.
دكتور عبد الحكيم، في قانون الحماية من العنف والإهمال الأسري 2013 وفي تجديد له 2017 under medical abuse، يعني لابد كل مستشفى يكون في كوميتي، والكوميتي هي اللي تتحكم في هذا الشيء. No drama in my hospital. No.
Excellent. Thank you. So maybe Khalid, we can benefit from your experience if the society want to tackle this issue in the near future, inshallah. Any other topic?
Yes,
to go. تفضلي دكتورة.
Thank you very much for this very important question. Actually, I noticed if we give adequate explanation for the family, and it is from, for example, from the consultant himself, and we give full explanation, we'll minimize the patient number who are really refusing to have stay in hospital, and just to know what is the reason behind their request to go against medical advice. Maybe the mother, she has some issue, maybe she is sick, maybe they have a social problem. So if we are flexible with them and we'll tell them, for example, she can go out on pass and come back, and we give some options for her, so the baby will have a checking of his TSB again, for example, or will allow him to stay in the nursery with without watcher. So this can help.
Excellent.
Sometimes.
So you are suggesting some other solution rather than to
yes,
be
plus the
like,
child protection team to be aware of this case, to send the social worker and from hospital administration, so they will feel that it is a big issue and they will not do this disaster for their baby. Okay. Thank you very much.
Professor Saleh.
Thank you very much, Dr. Abbas, for excellent overview. The topic is very important and we all agree, but there are some problems. I think we can work on them and solve them. And I agree with Dr. Khalid regarding the role of the Saudi Neonatology Society in developing guidelines for this important topic, especially nowadays we see some changes, new recommendations. And personally, I'm not sure what other hospitals, what other pediatricians or neonatologists in other hospitals, how do they manage such cases, or how do they prevent it if they don't have clear guidelines? And I think this is one of the important things. If there's any recommendation for this meeting is to come up with new guidelines for the jaundice.
Very important. Thank you, Professor Saleh.
Okay, can I comment, Dr. Abdul Hakim?
اتفضل دكتور.
Okay. First of all, actually, all our topic today is very interesting, and most of them have medico-legal issues. If we start from the end, like Dr. Abbas, first of all, I noticed that this baby bilirubin, when he came around 600 something, right? Yeah. So for me, I would proceed for exchange right away, rather than intensive phototherapy. Maybe this will make the family will accept. I mean, phototherapy not expected to drop it significantly down. Second point, comparing the old nice guideline or phototherapy versus the new American, which is a little bit confusing sometimes. They start phototherapy based on the threshold rather than phototherapy or exchange and so on. Like there are 4 charts for the hyperbili, while in the NICE only 1 chart contains everything. When I compare the 2 groups, very much similar. There is no much difference actually.
That's why I said that we have to have our own to review these guidelines and reach to a conclusion on one of them. As I mentioned also, I was comfortable with the previous guidelines. I think the threshold of the previous one is good for our place also, rather than to increase it. Regarding the 600 micromole level, actually, when the baby first time was admitted, the bilirubin was 340, and that's the time when we did the phototherapy. But the next day when he came again, the bilirubin was 600. 600. We went ahead and exchanged the baby, but the baby was symptomatic already.
Okay, thank you, Abbas. Can we shift gear a little bit towards the medico-legal issues? Because I think Abdul Hamid here, I'm interested to ask you, Abdul Hamid, about, like, when there is a medico-legal issues, if there is the service or the doctors are insured, where is the insurance company come? Are they like, coming, instead of him, they are doing the job of defending him? What they do? Are they like doing any part in this?
The insurance company usually will protect the doctors, لأنه من يوم ما تصير قضية على دكتور يمنع من السفر. فالإنشورنس سووا كفالة غرم وأداء.
So they release him from being prevented from traveling. But what about the real case? Like, can they defend him, in the court? Because they are paying money, and I know some hospitals here in Riyadh, they are insuring all their doctors.
Usually the judge, they ask for the doctor himself to come. They don't rely on the muhami or insurance company. The doctor himself should come to present himself.
Can I make a comment in this regard? We are insured in my hospital. Everybody is insured, all physicians. But there are legal department also. But when we go for investigations or to the judge, we go ourselves. But then there is insurance already. You will not pay money. You are not going to pay anything. And the legal, they usually also.
But this is upside down insurance. Why they are insuring us? So if we will defend ourselves.
No, we have to go for investigation. You have to go.
That's part of the investigation.
Yes. How will the judge decide? You have to ask your questions.
Excuse me, Dr. Hamid. Many times they are reporting the mistakes of the physician. On the other side, there are tons of physicians have been complained in the newspaper, and tend to be they are not guilty, and there is nothing done, compensated for them, or protected. So the people, they are always looking to the bad side of the physician, but never look for when they complain. There is nothing wrong from his side.
So we advise the doctors who think that this is da'wat, not legal for him. He can go to the Amara and complain against to the parents who complained against him, or to the patient. رد اعتبار.
He need a leave to do that.
But I think also when you write a complaint, or when they write a complaint, there is an issue there. They say if this complaint is false or so, you are going to suffer. إذا كانت شكوى كيدية أنت تحاكم أو شيء من هالقبيل. أنا ما كنت في لجنة المخالفات كانوا الأهل يوقعوا هذه الورقة.
Excellent. We should have some other questions there on the top. Sorry.
أنا هاب كومنت.
يا خالد ما تتدخل إلا لما نعطيك الفرصة.
طيب أنا رافع يدي أهو.
طيب أنا عارف بس استنى شوي. طيب. في هنا يد ثاني مرفوع. تفضلي.
بسم الله الرحمن الرحيم. السلام عليكم. I am Dr. Jubaira Abuat from Abha Maternity and Children Hospital. I'm working under the umbrella of Dr. Mufara Asiri. I believe with Dr. Jubara, Lama should not be allowed in these intensive care units because it is very risky. As worker in that maternity hospital, I am the frontliner in the postnatal, antenatal. I'm the one assessing for this jaundice, and we struggle about the parents like this. For me, I'm telling them, if jaundice goes too much high, your baby will go connectorous. Then they will change their mind.
Excellent.
My question. Does this Lama paper protect us? Does our responsibility stops there? Of which my conscience, I don't stop there at the Lama paper. Is this acceptable in the court? Will this protect us?
It has been said clearly by Professor Abdul Hamid that if you sign this paper against medical advice, you are clear from legal point. It should be fine, but we are talking about our responsibility as a doctor different way. But any other thing, Dr. Majid?
Thank you.
We will come back to you, Khalid.
I think to start with, at least that we should not allow the resident to accept parents signing without informing the consultant on call. I think the consultant on call should be informed if this is going to happen. And maybe if he comes, I agree with the doctor, I think most of them, at least during my years in Saudi Arabia, can be resolved by the consultant with proper talking.
If the consultant here, Majid, is available, many of them are not available. But anyway, Khalid, we go back to Khalid.
Another comment for this resident. I think resident should not discharge baby from nursery. We allow only the senior or assistant consultant who do a discharge for baby. No resident allowed to discharge. They can examine but not discharge.
Can I make a comment? After this incident, Dr. Majid, he said what has been done already, that residents is not allowed to discharge Lama, and there is a policy that the consultant, if he's not available, he needs to be called and talk to parents and the social worker. But this baby was admitted to the ward, doctor, not in nursery, not in intensive care. Intensive care, we don't discharge them Lama, definitely. Thank you.
اوكي خالد دانش بس اختصر الله يخليك.
يعني I was in the medical legal committee in Jeddah for 6 years, and we used format from the governor, the princes of the Jeddah or the Mecca, that before we investigate, the accuser should read and sign a paper that if his vague complaint, the doctors has a right and the hospital concerned has the right to sue them or to sue here the family in the court. 80% they don't come back. We give him 1 week to read and sign, and that's what an official letter من أمير المنطقة في مكة.
هذا smart way, excellent.
يعني if we have this, we could save time.
Excellent.
For the medical legal. I've been accused 2 times and it was a fake. يعني حماية ما قدرت أحمي نفسي.
Excellent. طيب بروفيسور سعد.
دكتور خالد بس تعليق على كلامك، احنا قررنا انه يقدم شكوى يدفع مبلغ معين، اذا جاته القضيه ياخذ المبلغ والديه اللي معها، لكن الامر ما موافق عليه الان، لازم من فوق يقول لك.
So it's just a suggestion, yeah.
My question is
مو نوقع يدفع مبلغ معين قبل ما يقدم اي شكوى على دكتور، المبلغ هذا يحفظ عندنا او يحفظ في الماليه، اذا جاته القضيه وكسب القضيه مع الديه ترجع له، لكن ما وافق عليه الان.
نعم. طيب سعد تفضل.
What about the newspapers when they, talk about these things in excitement way from one aspect? Is it possible for me as a physician, if it's turned to be not the right to sue the newspaper?
Newspaper and Twitter. Now everybody complaining in the Twitter, really. And there is our colleagues, they write their name clearly, Dr. So-and-so, he had this and this. So I think also, no, but Twitter, like it's hugely...
No question about the newspaper right now.
But even in Twitter, they can bring them back if there is a law about it. تفضل دكتور عبد الحميد.
Newspaper, you can complain للأمارة، تحط صورة الخطأ أو المقال وتقدم شكوى عليهم، بس عن طريق الأمارة مو عن طريق اللجنة.
نعم. We can end by 2 quick questions but short, please. Dr. Ali.
Thank you very much, Dr. Katan. I have another perspective actually for the point of journalists. I wonder if home care, visiting these babies at home and doing the necessary investigations by dedicated nurses and residents, I think this is almost the problem, because one at a time visit in the clinic is not enough, because jaundice is a dynamic process. So it's not enough to see them once. Excellent. Home care is the best solution in this country, I think so.
Excellent. You are affected by the British way of doing things.
This is
any comment, Duvara, about it?
Actually, some hospitals, they have home health care, but only for sick and,
terminal patient.
For terminal patient, but they didn't do it in pediatric, like anyone with pediatric. So we need really a lot of resources, a lot of personnel, a big program to encounter for the home health care or home visit, like UK or Canada.
Yes, this is the only one. It's not only jaundice, it's many things. That babies are not well, cardiac, this can be picked up.
Yeah, breastfeeding and jaundice, and this is what happened. But I think, inshallah, in the future, but it really needs a lot of resources.
شكرا جبارة.
Can I make home care comment?
I will give you time. Just a second. تفضل دكتور. Short, quick.
Okay, thank you. Just it's not a question for Dr. Jubaira. It's only interesting to know what happened to the interesting case you present, methyl hemoglobinemia, this type 2, picked up early and they started treatment early. Just any follow-up for this case, or or has any problem?
Yeah, we see her in the clinic. Unfortunately, she started to have some delayed. So this is at age almost 5 months. And to old cases of type 2, it's not carrying a good prognosis, even if you start treatment early. Because when we look to her cord hemoglobin, it was 30. So I think she had sustained, injury with neurological impairment earlier. And all the cases which report with type 2, it's a lethal. So nothing has been reported as a baby who survived with type 2 methemoglobinemia.
Thank you. Now we have two quick comments from the podium here. Dr. Abbas first.
We have the experience of having home vaccination in my hospital, and we have difficulties. Sometimes if the father is not at home, they will not allow the team to go in. Okay?
I see.
And sometimes they wait 1 hour. So, it's so many problems, but it's going. Home vaccination is going.
Thank you.
Maybe we can.
You charge them, ya Abbas? You charge them?
Insurance companies, yeah.
Okay, if you charge them, fine. It's okay. Then that's good. Last comment from my colleague, Dr. Abdurrahman Matar. تفضل.
Yeah, I just want to saying about blood transfusion complication and mentioned by Dr. Tariq Awda. First of all, very interesting. I mean, I have written and in the process, inshallah, for publication 2 papers about blood transfusion. And one of them, I come up with the conclusion that in Islam, blood transfusion is not permissive, يعني مطلقا. What we know, just for every baby we are giving blood, as Dr. Tariq mentioned, there is risk. It may be minor, but it is there. So, and many times we transfuse the babies for no good reason. So I have good data for a lot of babies have been transfused, and they have significant morbidities comparing to those group who's not transfused.
طيب عبد الرحمن. إذا نسمع كومنت من طارق.
Yes, thank you. I totally agree. I think the first rule in transfusion medicine, not to transfuse. So if you can do anything without transfusion, that's the first rule. But definitely, in as we see in the hyperbilirubinemia, you need to have some areas where you need to use the blood. Minimize that by all the measures that you need to take, the safety of the blood that is being taken care by the blood banks, and the safety that should be taken care by the ordering physician, ordering the compatibility. Be sure that the recipient of the blood is in a good shape and in a need for that. And adding to that, a follow-up. And unfortunately, many of the transfusion, the patient receive a transfusion and left over. No one follow-up. And in the future, when he or she needs a transfusion, they discover that there was a miss in his previous transfusion, and now he has incompatibility issue or a complication associated with the transfusion.
Thank you. At the end, I would like to thank all the podium, all of the audience. Thank you for waiting with us till the end of this session. And I would like to ask you to come back after the prayer and lunch. We'll start at 1:15. We will have our last session, which will be, you will see again Abbas Al-Amran. He will be there in this session. And we will have the research papers, and the competition will be to choose, 3 winning research afternoon, inshallah. We will try to conclude the whole meeting by 2:30, inshallah. So come back and enjoy your lunch. Okay, you want to do this thing.